So, all the different devices, doing my absolute best. Let me turn this down a little bit in the background. I needed some soothing music to motivate myself to, have this moment with everyone. My goal here tonight, let me just start out actually by introducing myself. I'm Birthmama Sekesa. I'm a community midwife here serving the metro Atlanta area. And so, my goal here this evening is to just bring some awareness about home birth options. This series is going to be a 9-week series. It's called Birthmama Speaks. And every week, Monday nights at 7, I want to talk a little bit about different things that you can expect in a home birth scenario, and just different things dealing with maternal care as a whole. So everything from like hemorrhaging to blood pressure awareness to how to choose a midwife, the difference between a midwife and doula, which is one of the things I intend to touch base on this evening. And so I'm just going to start, right? So welcome to the ride. All right. So, home birth versus hospitals, right? So, I get this quite often. Not so much understand the last couple of years as much as I did, I would say, leading up to 2020. There's definitely been a shift and a resurgence in home birth participation and awareness, and people that's just seeking out that option for their care. And a lot of it we understand was due to the awareness of what was happening in the hospitals. And several of the hospitals here, specifically in metro Atlanta, and then also I'm certain abroad as well throughout other states. Partners weren't allowed in the birthing space when mothers would go in to deliver. There was a short window of time. Some states it probably lasted a week. In other states, it may have lasted as long as a month. Some states it may still be present to this day, but certainly here in Metro Atlanta, the first time this was lifted up where partners weren't allowed to go into the hospital space, I would say it was probably about April of 2020. And during that time, it was very alarming for a lot of expecting families, as you can imagine. So, because of this, many families decided that they wanted to hire a midwife and have their babies at home. And so, when you have your baby in a home birth space, first of all, let's just accept and understand that birth is sacred, right? So let's start there. When you really center yourself in the ideology of the sacredness of birth, the spiritualness of birth, you have a whole nother human being coming through into this world, right? And you, as the mother, are a vessel for that life to come forward and through. And so, in a home birth setting, you have the opportunity to really create a very intimate space for yourself and an intimate space for your child to be birthed into. And what that can look like is you have a lot of control over your environment and who you want to be present in that space. So, from the midwife and the doula that you choose to be alongside you at that birth, alongside the your mother, if you want your mother to be there, your father can be there, the grandparents, that is, sisters, cousins, aunties. I always encourage people to keep their birthday party short, right? Because a long birthday party list can certainly inhibit the progress of labor. But nonetheless, you have the option to have people participate in your birth experience, whoever you choose to be there. That's one big plus. You can decorate however you want. I've been in some very beautiful home birth spaces where people will put up the nice fairy lighting or the string lighting, the LED lights as they're called. They'll have different affirmations on the walls and different color fabrics maybe hanging around in different spaces. And if they're choosing to have a water birth, they may center a room just specifically dedicated to that water birth space. So it can be very inviting. And that's one of the things I love about being in a home birth setting. It's very comfortable in that way. You have access to your own shower, access to your own refrigerator. We don't restrict you from eating in a home birth, right? We want you to eat. We want you to be selective in what you eat, right? We don't want you doing too many greasy foods or spicy stuff or fatty foods, anything that's going to upset your stomach, of course. But from there, we really want you to eat to stay energized, right? So we encourage you to eat so you have access to your own refrigerator, access again to your own bathroom, your own bed. It just shows up differently, and for many families, it is a good fit for them. And so, in that vein, let's talk about what it looks like to be a home birth candidate, right? So, being a home birth candidate means that you really need to be healthy, right? You have to be, know your weight has to be acceptable. You can't be gestational diabetic. You can't be hypertensive or preeclamptic. These words, I know I'm throwing them out there, like high blood pressure basically is preeclampsia, or hypertensive all falls under the umbrella of high blood pressure. Like I said, gestational diabetes. You really want to be as healthy as possible for a home birth. Most home birth midwives are only going to accept you if you are low risk, no risk, and some home birth midwives will only accept you if you've had a baby before, and we call that a proven pelvis. Some midwives will only do your home birth if you have what's called a proven pelvis. It means again you've birthed a baby before, and that's because sometimes we don't know what to expect with first time mothers. So being a home birth candidate can look different based on the midwife and what parameters that she's comfortable with working in. So you definitely want to have that conversation one on one with the midwife that you select, but ultimately understand that you have to be healthy. It has to be a situation where you can pretty much birth your baby on your own. Honestly, we don't advocate for that because things come up in home birth situations that require skills and expertise. However, those are the candidates that we're looking for, people that are healthy, that maybe need a little extra help with their nutrition and their exercise and their focus, and just cultivating or continuing to have that healthy pregnancy. But those are the people who are candidates. When you risk out, things that can risk you out of a home birth situation can be if you're not following the guidance of that provider, that midwife, the person who's trying to get you to eat healthier, make better choices, make sure this baby is growing optimally. We expect your baby to show some significant growth every time we have a prenatal visit. Your uterus should grow in centimeters, and that's those centimeters correlate with how many weeks you are. So if you are 24 weeks, we expect you to measure about 24 centimeters. You can't be measuring 27, 28, 29, right? You can't be measuring 20. That right there are signs of something else going on. So we want your baby to be growing at a healthy rate. So we're looking at that, and we're maintaining as best we can. We're intervening in most cases with holistic and natural remedies to help you stay in those parameters of having a safe home birth. Your blood volumes, we'll talk about that in another chapter of this 9-week series, have to be up to par, right? Because you can't risk out, you can't be at risk of hemorrhaging. So we're very big on you maintaining healthy blood volumes during the pregnancy. So being a candidate again looks like just being a healthy person overall. That's the goal. Another question that I get often is, what is the difference between a midwife and a doula? I get this quite often. I think now that there is more awareness of doulas, I like to call them labor support specialists. Um, More people are understanding what a doula is, but not necessarily their scope of practice. And sometimes it kind of bleeds into the scope of practice of a midwife. And they're not the same, right? They're similar, but not the same. Uh, to keep it simple, a doula is non clinical support, period, right? They support in a variety of different ways and dynamics, but they are non clinical. To become a doula, it may take you a year overall, right? Most of these trainings that doula that certified doulas usually are anywhere from a weekend to maybe a few months. To become a midwife, you're going to train upwards of 4 to 5 years, right? Most of the pathways of midwifery, which we'll talk about next, it's going to take you anywhere from 4 to 5 years to complete your midwifery training, right? And so a lot of that training is in clinical management of care of the pregnancy, the birth, and the postpartum. And so that's a basic nutshell of the difference between a midwife and a doula. Um, let's see, another question that I get, as I was mentioning, on types of midwives. So I get this often also, different types of midwives, right? So the difference between the different types of midwives, right? You have the nurse midwife. Well, actually, let me take it from the other way around. I'm gonna start with the original OGs were the traditional midwives, right? These were you go into your Bible even and they talk about Shifra and Pua. They're talking about these grand elder great midwives that just that heroic woman that was reared in the family and or in the tribe, in the village, and that person that was identified as she's the one that's going to help facilitate births. And not only did the grand traditional midwives facilitate births, they also were very instrumental in helping. They were the original hospice. They helped to usher life in and out. Midwives are considered gatekeepers. And so, at once upon a time, and still very prevalent in many countries and places all around the world, midwives still hold that position where they usher life in and out. And so those type of midwives, they were trained, like we like to call it, from mouth to ear. They were reared in that work through some kind of apprenticeship model. There was somebody that looked at them when they was a child and said, "Hey, that's the one right there. I think she's going to be a great midwife." Or they just heard the call on their own and they started going to births. And lo and behold, before they knew it, they was the midwife in the village, in the tribe, however you look at it. So those are your traditional midwives. Nowadays, a lot of those women that consider themselves, or those people that consider themselves as traditional midwives, they go on to build more of a skill set and life support skills. And so definitely that's what I am, a community traditional midwife. And I continue to build upon my skills and training. As such, I was trained mouth to ear from my preceptors. Shout out to Mama Saran out there. Shout out to Mama Oshun, also known as Mama Nasra, Mama Niasha, Nika, Mika Hall out there. I was just, engulfed in so much love by several midwives here in the Metro Atlanta area. And they helped to rear me and teach me and guide me into this work for about 6 years. Six, probably close to 7 years. So it took me a while to start seeing clients on my own. It was definitely a strong walk for me to lead. So yeah, that's a traditional midwife. Now you can become certified as a traditional midwife if you follow what's called the certified professional midwifery route. It's also called direct entry midwifery. That particular midwifery pathway has a governing body called NARM, National Alliance of Registered Midwives. You can look them up. And they have a process that you can go through. And there are some schools that even are erected in different states that will honor the direct midwifery pathway, or also called the certified professional midwifery pathway. It is the most recognized, or one of the most recognized, direct midwifery pathways nationwide. And so that's a certifying one. However, some states do not honor it, and Georgia is one of them. Georgia does not honor the certified professional midwifery pathway. Licensed midwives is another one. Some states actually license their own midwives. Georgia does not. We are bordered by states that do. So Florida, Alabama, Tennessee, South Carolina, they all license their midwives. Georgia doesn't currently. We have several midwives that are working aggressively. Shout out to Karina Edwards and Mama Saran again, and Mama Oshun, several midwives out there that are working aggressively to help change the laws here in Georgia. But currently, it is an unregulated state for home birth midwifery. But again, we're bordered by states that do. However, home birth is legal in this state, right? So some states like Mississippi, to even the choice to have a home birth is illegal. Alabama just changed their laws in 2018 and legalized home birth. And so just so you have some awareness and understanding of what you're up against and what you're looking at when you choose to have your baby at home. And so those are two different types of midwives: direct entry, also traditional midwives, and then you have the nurse midwife. So nurse midwives are the ones that most people are familiar with. Nurse midwives tend to work in hospital settings and birth centers, and some of them do home births as well. We have some nurse midwives here in Metro Atlanta that also does home births. Nurse midwives, they tend to go to universities for about 4 years. They get their bachelor's, and then they move on into getting their master's into midwifery. And we talk about that again in the book. It's again about a 5 to 6 year process, no different than my own in most cases, but they're more rooted in the medical model of and more clinical. So as a nurse midwife, you're gonna receive a lot more in-depth information about clinical skills than you do in most cases as a traditional or a direct entry midwife. Um, that's the greatest difference, I think, between the two, and just how our learning pathways are. And so most schools offer some kind of, many schools, I should say, not most, many schools offer some kind of nursing um, pathway. And then once you finish that, you may have to transfer to a different school in order to get your master's in midwifery studies. Okay, so the next thing we're going to talk about is being a home birth candidate. Oh, we talked about that. We talked about being a home birth candidate. Um, let's see what to expect from your midwife, right? So, like, say for instance, you're a home birth midwife, and you welcome, sis, you welcome. Um, you decide that you want to have your baby at home, and you've hired a midwife. What can you expect? Okay, so I've mentioned this a little bit at the top of this video, but really, your home birth midwife, she's going to govern, or not govern, she's going to help manage your prenatal care. Most home birth midwives in Georgia, we lean into a lot of natural remedies. So that's going to be looks like vitamins and supplements and herbs and aromatherapies. And we also look at our other allied care professionals like reflexologists, chiropractors, acupuncturists. That's our realm that we tend to refer out to, and we're closely connected to them. And most midwives have a network of those particular practitioners that we refer out to, and that's because again, that's typically our scope, that natural realm, especially again here in Georgia, where it's an unregulated state. For what we do, you don't necessarily have access to pharmaceutical drugs in that case if you're a home birth midwife. And so, that has its pros a lot of times. In some of these states where home birth is regulated or it's licensed and governed, in those situations, the midwife is typically working under the supervision of an obstetrician. And so she's working in close partnership with that obstetrician in some capacity. And that obstetrician would have to then sign off on that home birth and say that, yes, this particular patient does qualify for a home birth. And that obstetrician also is offering collaborative care with the midwife. So if something comes up, say for instance, a urinary tract infection, UTIs are pretty common in pregnancy, then that obstetrician can write in a prescription for the patient, based on the recommendation from the midwife. And so that is a beautiful model that I would love to see Georgia adopt, where we can work hand in hand with our obstetricians and provide the best, most optimal care for our patients or our families, right? But in a state like Georgia, as I mentioned, we tend to have to lean into naturopathic options, which is a plus in a lot of cases as well, because we're dealing with low risk, no risk families. So in those situations, we're looking at, again, herbs and things of that nature. If you were to have a UTI, we're going to recommend something like maybe cranberry juice and some other herbs to complement that, which I won't mention on this chat. Some other things that you can do to help, heal from whatever it is that you're dealing with. Drink more water and things of that nature, some natural remedies. So our prenatals tend to follow the same OB model. As a home birth midwife, you're going to see your patients about every month until they're 28 weeks. And then from at 28 weeks, it's every 2 weeks. And then from 20, it's every 2 weeks for 28 weeks. And then every week at 36 weeks until birth. Now, I will say for most home birth midwives, and this is worldwide, thank you, World Health Organization, because it looks a little different than what you will see for ACOG, which is the American and Gynecologist guidelines for home birth. Here, I'm not for home birth, but safe birthing. They usually recommend up to 41 weeks. And in many cases, they're even inducing families at 39 and 40 weeks. But the safe window for home birth really is up to from 37 to 42 weeks. Right. And so we definitely start monitoring and looking more closely around, let's say, you get to be about 40 weeks or so, we might send you in for this special type of ultrasound that's going to look at the integrity of the placenta. It's going to look at the fluid volumes in the sac. It's going to look at the baby. It's called a neonatal stress test. So they're going to look at the viability of the baby. And so we love it when we can get a test like that around 40, 41 weeks. And it just kind of, it gives a grading system, and it lets us understand, is it healthy for you to continue to stay pregnant up to 42 weeks. And so again, that's a beautiful model, because in most cases, a healthy mom is perfectly fine carrying her baby up to 42 weeks. And that's really good for y'all to know, because especially if you're expecting, so many people get anxiety around that 40-week mark. And 40 weeks doesn't necessarily, it's not an expiration date, right? It doesn't necessarily mean that your baby's going to be born at 40 weeks. As a matter of fact, most first-time moms on a world level deliver around 41 weeks and 2 days. That's been a world norm for I don't even know how long. So, I mean, once you wrap your mind around that, you understand that 41 weeks is, again, as long as your baby is fine, you have healthy fluid volumes in your sac, and your placenta is still thriving and functioning at its best, you're fine. You're fine. You're perfectly fine. Baby will come out. Baby fine. No worries. It's good for you to understand that. So these are some things you can expect from your midwife. Most of us, that's our prenatal schedule. Our prenatal visits are going to be longer, whether that's 30 minutes up to 2 hours. I tend to hold space 2 hours for my families. And that's bonding time, it's teaching time, it's getting acquainted, it's questions and answers, and that time really flies. Me thinking, oh my gosh, 2 hours, oh my goodness. And I don't hold them hostage and say you got to stay here for 2 hours, but it's time that I allot for all of my clients so that they can sit and feel comfortable. For one, I live kind of far from the city, right? Most of my folks travel about an hour to see me. And so, I don't want you to come in for 15 minutes and then have to drive back an hour home, right? So I really do my best to try to kind of hold that space, make it very comfortable for my families. And, we might sip tea, we might have some snacks, we might, let the children play, whatever that looks like. We might go outside when the weather is warm and sit. I've sat and cooked meals with my families. It's a more intimate relationship. And that's just how I work with my families. Not all midwives do that. I don't want to set the bar too high or too low in some cases. I've heard of some midwives dedicating a full day to their families, and that's a beautiful thing as well. But your time with your midwife is going to be significantly longer than with your obstetrician. It's going to be, like I said, anywhere from 30 minutes to upwards of a couple of hours. And so, yeah, that's that in and of itself is a huge difference. You have an opportunity to really dive into a lot of questions. And what I find with that for me is it gives me an opportunity to really understand what's happening with this family. Because in some of these situations, had I seen them and just let them leave, I would not have caught on to little keywords like I eat ice, I'm about to stop at this QT up the street and get me a thing of ice. Like, wait a minute, how often are you going to QT? And then, that conversation leads to me discovering, oh, you're anemic. Had I just seen them and let them go, then I would not have picked up on that. And just sometimes just having that extended conversation gives me time to troubleshoot. and chime into something else that may be needed to help, continue to facilitate a healthy pregnancy. So you can expect to have more time with your midwife, a more intimate relationship in most cases with your midwife. Definitely the births. Most of us offer home water birth. Some of us offer births in a birth, but again, water births is very trending right now, and whatever that may look like for that particular family. And then we tend to stay afterwards and clean up after the birth. We tend to come with a team of 1 to maybe 3 additional people, depending on that midwife. I typically travel with 1 or 2 additional people, an assistant and maybe a doula, or a couple of assistants, an assistant and an apprentice. Just depends on the scenario. And then from there, you can expect, again, we stay a few hours after the birth to kind of clean up, feed the mama if she needs to be fed, make sure that everyone is good, baby is thriving. I always say we got to make sure that mama's bleeding is under control and the baby is breathing well. All of that is very important. And then from there, I come back the next day. And so that's what most midwives do. We come back anywhere between 24 to 36 hours after the birth just to check in on mom and baby and be certain that all is well, right? And then from there, we tend to come back again about 3 days after that. And that's norm. That is our norm. And I think this is where we really do prevent maternal loss, because we're doing these check-ins. And not only are we present in coming to see you, you can call us any day of the time, any time of the day or night, and ask, hey, is this bleeding norm? I get pictures all the time, pictures of clots in the toilet. Like, I know that's graphic, but it's the real thing. I have a clot in the toilet. Is this a normal clot, right? They might send me a picture of their pad. Am I bleeding too much? And then we get to have that conversation. Or my baby's making this sound. What do you think I should do? We're real time, live, 911 to some degree, right? Information, expert information and guidance that you can expect from your midwife. Yeah, and then from there, it kind of looks different per midwife. You typically will get at least 2 visits from your home birth midwife. Some will continue to see you upwards of 6 weeks. Some go as far as 2 weeks. You just have to have that conversation again and see what works for you. So, transport. So what transport means, if you're at home, you're laboring at home, and all of a sudden, and it's usually not all of a sudden, to be honest, but something shows up in that labor that um, no longer qualifies you for a home birth, right? At this point, something has shown up, and again, it disqualifies you. It made this midwife uncomfortable, uneasy, or it's a red flag for us. And it's like, okay, we got to go to the hospital. What kind of things is that, right? So I will tell you right off the top, the first one that we look at is meconium. If you don't know what meconium is, it is the first bowel movements that babies have, right? In utero, this beautiful sac here, somebody gifted me this artwork behind me, but in utero, babies pee all day. They pee all the time. Most of their amniotic fluid is actually their own urine, right? I know it sounds gross, but that's what it is. Is baby urine is sterile. They never had any food or anything in their systems to make it toxic. But a large amount of their amniotic fluid is their own urine, but they should never poop. And we don't like that. So when babies start to poop in utero, that can be a sign of distress. And so if the amniotic sac bursts, better known as water breaking or the water sac breaking, we look at that as a concern, especially if the not just the sac breaking. I apologize, but if the sac breaks and it's discolored. So if it's discolored, there's a spectrum that we look at. It can be as green as this plant behind me. It can be as black or dark as my hair. It can be very yellow and almost look like urine even. But depending on what it looks like, some midwives will transport immediately. Some midwives might sit with it and look at it and see if it clears up over the next hour or two. It just depends on the confidence of that midwife and other factors that she may see that show up alongside that meconium. I'll tell you right at the top, if we see meconium and the baby's heart tones aren't favorable, that's an immediate transport. We're going in. Meconium alone, I will say, is granted on that midwife, right? Some midwives transport based on the color spectrum. Some midwives transport immediately. Again, it's the comfort level of that particular midwife. So that's the number one. Prolonged rupture of membranes, right? Or also known as your sac being broken for an extended period of time. So most hospitals will, once your water bag or your amniotic sac ruptures, they're going to send you into the clock starts to tick, and most hospitals will give you about 24 hours. Some of these other more baby friendly hospitals will give you upwards of 72 hours. That seems to be the standard, and it fluctuates with your midwife. Again, you're dealing with the comfort level and the training of that particular midwife. Some of us, 24 hours, you've been ruptured. There haven't been any consistent contractions or progress of labor. Now it's time to go. You have some midwives that give you upwards of, I've heard, as long as 5 days. And it depends, again, on the comfort level of that midwife. I typically go about 72 hours. Depends on, again, other things that I'm seeing, what is showing up in the moment. I try not to just say your water bag is ruptured, we got to run to the hospital. The reason why it is a concern, because the risk of infection starts to increase the longer your sac has been ruptured, right? And so, especially if you're dealing with what's called GBS or Group B strep, which is a bacteria that lives in our colons for the most part, and it can migrate. Is very all bacteria is opportunistic, right? So it might want to migrate itself into your yoni space and then kind of swim its way up into the sac, and it can make babies sick. It can make you sick even. And so this is the concern when the bag has been ruptured for a prolonged period of time. And that's one of the reasons why it's a concern. And again, you're dealing with that particular midwife. Anytime the heart tones are funky, right? They're unfavorable, you're going to go in. We're going to transport, right? The main reason we're doing this is we come with very limited equipment in a home birth. Most of us carry oxygen. Most of us are neonatal resuscitation trained, but I will promise you, none of us wants to use that skill set. None of us are going to a birth eager to say, oh, I just want to resuscitate this baby. Nobody wants to do that. And so it's very unnerving when you have to do it. It's a skill set that you have in the case of an emergency. However, if you can prevent that at home, that's what you want to do. And so if you have heart tones from a baby that are unfavorable, we're transporting that. You're not even going to play around with it and wait to see if the baby's going to be okay. No, let's go. And very similar in the hospital. Usually they do a C-section in a lot of cases if the heart tones are unfavorable. So that's another one. What we said, meconium, we said unfavorable heart tones, we said prolonged rupture of membranes. Vital signs. If your vital signs aren't favorable, right? If you start showing signs of a fever, as the mother, of course, you're showing signs of a fever, we're going in. Because if you're showing signs of a fever, that can mean your body is dealing with some kind of infection. Babies are very temperamental in utero. They like for that environment to stay around 98.6. If anybody has a fish tank, you kind of understand fish, especially your tropical fish, right? Think of your baby as a tropical fish. Tropical fish, they are very temperamental. You have to get heaters, right, to go in that tank to maintain, a balanced temperature, or those fish will die. Not to say that for your baby, but it can be very detrimental when the temperature is off, which is why pregnant people should never go into saunas or hot tubs, because it can make their babies overheat. And so for these reasons, if you're dealing with a fever, the body is overheating itself, we need to transport. If your blood pressure is creeping up, we're going to transport. So all of these are reasons why you can expect to transport. Another one, probably less commonly spoke about, but I have definitely seen more often than any of the before mentioned, is maternal exhaustion and failure to progress. Right? So if a mother starts becoming tired, and this is why, if any of my people are watching, I always ask you, what kind of exercises are you doing? What kind of moving are you doing? We want you to be mobile and exercise in order to help build stamina for birth, right? Because the best analogy that I love people to share is you wouldn't train for a marathon the day before or on the day of. If you were training for a marathon, you would start training weeks, in some cases months before the actual event. And that's what we want you to do for birth, because birth is a marathon for many people. Not many of us have the opportunity to just have these short bursts, 5, 6, 8 hour bursts, which is really short, whether you believe it or not. A lot of times you're in it for some time, for hours and hours and hours. You need to maintain your stamina for that journey. And so the best way to secure that is with exercise, going for walks, daily walks. Shout out again to Mama Saran. Her and her daughter lifted up the maternal wellness hikers here in Metro Atlanta. And they, every Sunday, for the most part, when the weather is agreeable, they're out taking pregnant families hiking on some trail throughout one of these nature reserves in Metro Atlanta, for these reasons, to keep people's stamina up and their blood circulating. So those are the main reasons why we would transport. All right, family. Thank you so much for tuning in. I intend to do this again next week, Monday night, 7 o'clock. I'm trying. My goal is to lift up this YouTube live. I'm multitasking, but you all are far more engaging on Instagram than on my YouTube live. So that is what it is. I thank you for sharing your time. It is a very valuable asset with me in this moment. I hope I was able to share something empowering and something of value with you this evening. So you know how to find me. You can DM me. My website, Love and Touch, LOVEN touch.com is the best way to get in contact with me. Emails, texts, DMs, I'm here for you. Y'all have a good evening. Peace and blessings.